Soumya, can you hear me?
Uh, yes, sir. Good evening, sir.
Good evening. Shall we start the session?
Yes, sir.
Okay. Here we have a 30-year-old female patient who present 1 minute. Just tell us this. Who presented with history of lower limb weakness, rapidly progressing to involve upper limbs. Also complaints of pins and needle sensation. Patient was recovering from history of cough, change in voice and fever since 2 weeks. Patient also complains of difficulty in swallowing. Comorbidities are dyslipidemia and atorvastatin 20 mg. Patient heart rate is 105. BP is 130/75. Respiratory rate is 28 cycles per minute. Temperature is 36.8. Oxygen saturation is 92% on 2 liters of oxygen. Investigation wise, ABG has been done. We showed pH of 7.35, PCO of 48, a PO of 56, bicarb of 26. On examination, patient has weak cough. Okay. So what are your differential diagnoses?
I can see that there is an acute onset of flaccid paralysis, which is symmetrical. Is it bilateral lower limb weakness, sir?
Yes, bilateral Olympic.
Okay, so it is an ascending paralysis. With this, I think I would like to consider um, Guillain-Barré syndrome, myasthenia gravis,
Okay.
and Eaton-Lambert syndrome.
Okay.
Any poisoning in terms of OP poisoning, and
Okay.
because it is an acute, may not be critical illness polyneuropathy. Apart from that, I would like to consider even ascending myelitis, any epidural abscess or hematomas,
Okay.
and
If
then young.
based on the history or comorbidities, can you have any other differential, possible differential?
Young patient with lower limb weakness, so it could be porphyrias as well, acute intermittent
Okay.
porphyria.
Okay, that's fine.
Yes.
Okay. Our differential in this case is GBH, as you told.
Yes.
Myasthenia gravis always you should keep a differential.
Yes.
Okay, transverse myelitis you said ascenic, but it's a transverse myelitis you should always keep as a differential.
Okay.
This patient was on statins, so you should always rule out abdomyolysis.
Abdomen.
Okay. Thus, if you know it's an EDIC exam, if the
Yes.
given scenario is patient has traveled from Pakistan, what additional you can keep? Recently traveled from Pakistan to whatever European country.
Bottles.
No. Poliomyelitis.
Poliomyelitis. Okay.
Okay. Just keep that as a differential for EDIC.
Okay.
Okay. Especially if they are given history of travel.
Okay.
Okay. In this patient, what are the signs? It indicates that verbal involvement or patient is might require intubation. What are the signs which might indicate?
In this patient is already having a weak cough, and ABG is showing, and it is an ascending paralysis. And third thing, ABG is already showing respiratory acidosis. However, it is compensated, and patient is already on minimal oxygen. With that 2 liters, she is maintaining 92%.
Okay. Anything else was there in the history other than that? History or examination findings? That's why you see in the exam, once given you the history, they'll give you time. But very important is that you should take down the points because they'll not give it again. Okay, and you don't have time to think when they ask you the questions. Okay. So you should know all the points which are there in that paper. They mentioned that there's a reduced cough strength was there.
Yes.
Certain swallowing was there. There was a change in the voice also.
Yes.
Okay, and patient had respiratory distress with the tachypnea and tachycardia was there.
Yes.
So you should remember all these things. They're not going to give you again this scenario. Once they're given the scenario, you should go through it and you should be able to answer it.
Yes.
Okay. So what bedside or clinical test you can do to assess that patient might need a ventilator?
We could do a single breath count. That is, ask the patient to take a deep breath and count from start counting, and anything between 20 to 25 is taken as normal. Anything less than that, probably patient can end up on ventilator.
Okay.
That is one. And second, serial ABGs to look for respiratory acidosis. And third thing, we'll have to assess the cough reflex and swallowing reflex.
Okay. Any
Uh,
test other than whatever you have examined,
Okay.
any other test which might indicate that patient might require ventilator? Are you aware of 20, 30, 40 rule?
Yes, yes, sir.
Can you tell
20,
me
30,
what it is?
yes, sir. Vital capacity less than 20, maximum inspiratory capacity less than 30, and maximum expiratory capacity less than 40 centimeters of water. There is, it predicts the ventilator required, the patient going on to ventilator. That is a incentive, that is a
Capacity or what is that?
pyro. Yeah, sorry, sir.
It's pressure, maximum inspiratory pressure, maximum expiratory pressure. You said
Pressure.
capacity.
Yeah,
Just
yes.
make sure that what exactly it is, okay, before.
Yes.
Okay.
Yes.
These are the few things which they say that if they are present, patient needs a ventilator.
Yes.
Okay. That is 20, 30, 40 rule.
40 rule. Yes.
Okay. What are the lab investigations you would like to do in this patient?
I would like to do a complete hemogram, and I would like to do the renal function test along with electrolytes. And also a CPK level, and rest other electrolytes like calcium, magnesium, phosphorus as well, and an ABG and a chest X-ray to look for any signs of aspiration, and nerve conduction studies,
Okay.
and would like to consider a CSF analysis as well.
What you'll try to find in CSF?
If it is, GB syndrome, then I would like to look at specifically the cytoalbumin dissociation.
Okay. Then anything else, imaging, any imaging which might help you in diagnosis?
MRI, brain with spine, mostly the
Sure.
spine I would like to cover, sir. Also.
Okay. Okay, fine. So you have covered most of the investigation. One thing I would have asked is the CPK.
Yes, sir, I did mention
Oh, you
CPK.
did mention. Sorry,
Yes.
that's my mistake then. Okay, and antibodies also.
Yes, antibodies.
Yeah. If we are suspecting myasthenic gravis, the acetylcholine receptor antibody,
Yes.
maybe as a part and parcel, if you're strongly suspecting, you might send it, otherwise you can wait out. Okay.
Yes.
Based on the investigation, diagnosis of GBSR, ADP was made in this patient.
Okay.
What treatment you would like to give in this patient?
So the management, again, I would like to go ahead with an ABC approach. I would like to keep a close watch on his airway and breathing. Currently, patient is on 2 liters oxygen. I would like to check his ABG serially. So I would like to place an invasive arterial line. And circulation, patient is already tachycardic. However, in GB syndrome, of course, there is an expected autonomic dysfunction. So the arterial line will help me in both ways, monitoring the labile pressures and the heart rate. And I would involve a neurologist at the earliest. And once the diagnosis is confirmed, I would like to go ahead with IVIG or a plasma exchange. In this case, IVIG, I would prefer IVIG because it is easy to administer. And with plasma exchange, we have to secure an HD catheter, need to involve nephrologists. So comparatively, it is cumbersome. So I would like to go ahead with an IVH.
In this patient,
Yes.
you would like to wait or you would like to intubate?
I would like to wait. However, I would keep a low threshold for intubation.
This patient had respiratory stress already, tachycardia is there, CO2 is retaining, and patient is having a swallowing difficulty.
Uh,
With all those things, you want to wait.
I would keep a close watch because she's still maintaining with 2 liters compensated. So I would like to wait. However, I will keep a low threshold for intubation. Sir.
Okay. It's better to intubate for this patient. Okay.
Okay.
Okay. What is the dose of IVIG you'd like to use, or Plex you want to whatever dose?
IVIG. I would like to 0.4 gram per kg for 2 to 5 consecutive days.
Okay, fine.
Yes, sir. Yes.
Okay, then along with that, in the exam, now what you do is along with that, use a fast track protocol. Just mention it off so that you don't miss anything along with all these things.
Okay. Okay.
Okay. And second aspect is invariably has a pins and needle sensation. They'll have a neuropathy. You can mention analgesia as gabapentin also in these patients.
Okay. Sir, because patient has sensory involvement, can it be the other variant? I was thinking of that.
No, it can be there, but it can. But at the end, whatever is there, your diagnosis,
The
it's
treatment
a
remains.
axonal treatment is the same.
Okay.
Okay. In view of hypoxemia and hypercapnia with respiratory distress, it was decided to intubate this patient for further treatment. Patient had a difficult area and was intubated with the help of anesthesiology team with a video laryngoscope and bougie. The patient was intubated and treated with IVIG along with other supportive treatment.
Okay.
Patient was clinically better with improvement in the muscle power by day 5. He decided to wean the patient off ventilator. How will you assess the readiness of patient to wean?
Okay. Initially, I would like to give a spontaneous breathing trial. And if I'm able to, if I'm able to, if the patient is successful with that, then I would like to extubate. However, explaining the family the risk of reintubation given the pathology.
My question is very simple. How will you assess a patient whether they can be weaned off or not? What are the parameters you look at?
First, one
What you do at
patient
the
is
bedside?
recovered. Patient is recovered from the underlying cause, and the patient is hemodynamically stable. And with this, I would like to go ahead with the spontaneous breathing trial. So, if patient is tolerating
What all things you look before going for weaning trial per se? What are the other things you're going to look in a patient?
Patient is, I would like to see his respiratory rate less than 20 beats per minute, oxygen saturating more than 90% with a minimal FiO2, and is not using and hemodynamically stable.
Yeah. See, what you can say simply is patient is conscious, alert, hemodynamically stable. Breathing parameters look better. PF ratios of more than 200 with minimal PEEP. The patient is having adequate cough. Even you can mention your RSB index in this patient. Okay, these are the parameters you are going to say in the exam. Okay. In the exam, no, these questions will invariably come. You should literally by heart these things. You should not think again and again what is the question, what I should answer. Okay.
Okay.
How will you wean the patient? What you now we come to the weaning techniques. What are the weaning techniques you are aware of and how long you would like to do it?
I would like to give a spontaneous breathing trial for at least 30 minutes.
Okay.
And a cuff leak test.
Okay.
And
What are the different weaning techniques you are aware of? What do you mean by spontaneous breathing trial?
I would like to put a patient on a CPAP with a pressure support, and we'll wait for at least for 30 minutes and look for respiratory distress or any hemodynamic instability. If patient and at the end of 30 minutes, if my ABG is satisfactory, then I would take that as patient is the spontaneous breathing trial is okay.
Okay. Any other techniques you are aware of?
Uh,
What are the
SIME,
different techniques? What are the different techniques of weaning which has been tried? Okay. See, as you know, SBT. In
yes,
SBT, there are mainly the three kind of things they use. TP trial, pressure support ventilation. That to pressure support means they keep 0 to 7 of pressure support without PEEP.
yes,
Okay, then CPAP.
yes.
Okay. Then your PSV per se can gradually come down on a PSV support and then try. In this with PEEP and pressure support, this is pressure support ventilation. It is a gradual process. Then you can, there are trials which have been done in SMV where they gradually come down on the rate, mandatory rate. But that is known to be prolonged the ventilation. That's why no longer it is used. Other techniques which have been tried is ATC and the proportional assist ventilation.
Okay.
Okay, these are different weaning techniques. As you
Yes.
told, in case of SBT trials, it's 30 to 120 minutes.
Hmm.
They have done a trial between 30 to 120. There's no difference between 30 and 120 minutes.
Okay.
Okay.
Yes.
And depending on the weaning difficulty, how will you classify the patient? Weaning duration?
Sim
Yeah, go ahead, try.
Simple weaning
Hmm.
and either it is successful extubation or it is simple weaning or a difficult weaning or a prolonged weaning.
Yes. What do you mean by simple weaning? What do you mean by difficult weaning? What do you mean by
Sim-
prolonged weaning?
Simple weaning is where there is successful SBT after the first attempt, sir.
Okay.
And difficult weaning is failed SBT at first attempt, and we might require at least 3 trials or at least 7 days to less than 7 days to reach successful SBT. And prolonged is more than 7 days to reach a successful SBT.
Okay. Okay, next week. Patient tolerated weaning criteria and was extubated in the morning of day 5, but noted to be in respiratory distress by evening. How will you approach this patient?
Uh, because the patient is a case of Guillain-Barré syndrome, I wouldn't give any trial of non-invasive ventilations here. I would straight away go ahead with the invasive mechanical ventilation. However, yeah, I think initially there was a difficult intubation scenario, so I would expect difficult airway here and keep a difficult airway cart ready and inform at least for an extra help from anesthesia colleagues, and go ahead and intubate the patient and initiate on invasive mechanical ventilation.
Okay. But I would like you to tell in more in detail. Whatever you told is okay.
Okay.
What if you say that again, I'll assess the airway, look for stratification. When
Okay.
you're preparing for intubation, you say that you should specifically use the word, I'll keep the difficult airway cart ready and an experienced anesthesiologist. Then from the equipment perspective, you should mention that I'll keep a video laryngoscope or fiber optic bronchoscope, bougie, stilet, supraglottic airway, surgical airway kit, all these things you have to mention.
Okay. Yes.
Okay.
Okay.
Because invariably each point will carry what exam they expect, we don't know. Each case might differ. But if you don't mention 1 or 2 things, you might again and land up in problem. Okay.
Okay.
Example, if whatever the rockurium or whatever you're using, you will be telling that you'll be keeping Sugaman decks.
Okay.
Okay. Pre-oxygenation is very important. Positioning, if ramp is required, we'll be mentioning that. Then you should say that you should have a backup plan and an emergency plan. You're using continuous for capnography, pulse oximetry during monitoring. Post-intubation, will confirm the tube by ETCO2. You should say all these points in the exam to make sure that you get all the points. Generally,
Yes.
they're expecting 5 to 6 answers in this. Okay, which 5 to 6 points they want, we are not sure. So make sure that you tell everything.
Okay, sir.
Okay. The patient had hypoxic cardiac arrest during intubation. Patient was resuscitated after 20 minutes of CPR. The patient underwent emergency cricothyrotomy followed by tracheostomy on day 8 and was tried to decrease the ventilator support, was unable to do the same. How will you approach?
Uh, I would like to look for I would like to look for causes of difficulty in weaning. I would like to investigate with, I will follow the ABCD protocol. I would like, now the airway is secured. I would like to look at any weaning issues due to the airway. Second, brain, of course, patient had an hypoxic cardiac arrest. So we do not know and recovered after 20 minutes. Not sure the brain status. Is it brain dysfunction? I would like to look at. And circulation, I would like to look at his heart. Is there any failures or any arrhythmias or any left heart or right heart failure? I would like to look at that. And also, I would like to look at the D for diaphragm weakness. And I would like to investigate with at least for electrolytes with calcium, magnesium, phosphorus. Uh, uh, so this is how I would like to go ahead with difficult weaning in him. And
Okay, you told more or less same way, everything. The
okay.
only thing is that you didn't mention positive increased secretions for pneumonia. We'll do a regular suctioning if required,
Yes.
start an antibiotic and all, adjustment of PEEP. In
Yes.
heart failure, always mention about I'll check for a diastolic dysfunction, I'll look for a pro-BNP and
Okay.
look for diaphragmatic dysfunction, especially in this case.
Okay.
Okay, these are more or less you told, but you
Yes.
should remember that all these points you don't forget.
Okay, sir.
Okay, just a question. What is the role of NIV in weaning failure patient?
I think in given with the background of JB syndrome, NIV I wouldn't consider because risk of aspiration is higher. So I wouldn't consider NIV in him. Sir.
Okay. So what they say is,
Mm.
can use NIV to facilitate extubation, to prevent reintubation in high-risk patients, to treat post-extubation acute respiratory failure. But generally, it should never be used as a rescue NIV. If patient, once you extubation, patient develops a distress, no, that time it is not going to help you.
Okay.
Okay. Don't use it as a rescue NIV. So patient continues to be comatose even after 3 days of this thing. How will you approach?
Now, so it is more than 72 hours after a cardiac arrest. So I would like to do at least MRI brain to prognosticate to know the extent of hypoxic brain damage. Second, I would like to involve the neurologist as well as get an EEG done. One, to rule out a non-convulsive status epilepticus, if at all. And also other causes of coma also need to be ruled out, like electrolyte disturbances or uh, uh,
Okay.
yes.
So whatever you said most likely is enough for exam.
Mm.
But to be on the thorough side, generally
Okay.
there are a lot of mnemonics which are going around for encephalopathy approach. You say that you'd like to rule out renal failure, liver failure.
Mm.
From the
Yes.
metabolic perspective, you might have to rule out hypothyroidism, you have to rule out adrenal insufficiency. Okay.
Okay.
You have to rule out hypoglycemia. Okay,
Okay.
you will be hyperammonemia. These are things which you're going to say in the exam. And all the electrolyte disturbances like sodium and all.
Yes.
Okay, for the completion purpose, if you remember the mnemonic, you can tell all those things. But
Yes.
two things you should never miss is imaging and EEG.
Age.
Okay,
Yes.
these are two things which are mandatory.
Okay.
Okay, I think MRI brain was showing hypoxic brain damage. I will communicate. I think we discussed about this already yesterday.
Yes.
What I'll do is I'll just keep it.
Mm.
We have some time. We'll try to do one more session.
Okay.
Okay. Okay, you can go through this. In another 2 minutes, we'll start.
Yes.
Hmm. Taking 3D. Shall we start?
Yes, sir.
Okay. We've gone through the history already.
Yes.
What are your differential diagnosis in this patient?
So my differentials are, first thing would be subarachnoid hemorrhage,
Okay.
and second would be meningoencephalitis.
Okay.
Third would be any hypertensive encephalopathy,
Hmm.
and uh, so that's
Okay. So you're going to include your IC bleed always. You are
yes,
going to put IC bleed and stroke in these patients. Okay, 40-year-old smoker, diabetic and all, right?
yes.
Okay, what initial tests you would like to do in this patient to confirm your suspicion?
Patient has come with a worst headache with
Mm,
neck stiffness. I would like to straight away go ahead with the non-contrast CT.
mm.
However, meanwhile, while alerting the radiology team, I would like to give patient analgesic to reduce his headache, and uh, and start him on.
The question is very specific here.
Yes.
What initial diagnostic test you would like to order to confirm your suspicion?
Non-contrast CT, sir.
Okay, very good. Then, if CT is negative, patient is over already 6 to 12 hours is over.
If it is already over, then I would like to go ahead with the lumbar puncture
Mm,
to look for xanthochromia.
mm.
Uh,
If CT is negative after 6 to 12 hours, okay?
yes, sir.
Okay, this is the CT scan of the patient. Now, what will you do?
The CT scan is showing subarachnoid hemorrhage with diffuse cerebral edema.
Mm,
I would like to start him on. I would like to load the patient with first thing an anti-epileptic. Along with that, I would like to give him a anti-edema measure, either a 3% saline or a mannitol. And I would like to do a CT angio as well, CT angiogram, to look for possible aneurysm as a cause of SAH, and would like to alert neurosurgery team, neurology and neurosurgical team of the patient. And post that, I would like to observe patient in the ICU.
okay. Um, um, can you do anything else you would like to do in this patient? You told already. You tried to convey that message earlier, but I told to wait till the. You should you should tell the answers where it is required.
CT angio.
So always you should mention ABC whenever any patient condition is there.
Okay.
Okay, you are going to control the blood pressure to prevent the rebleeding. Target SPP of less than 160.
Then 160. Yes.
Okay, then you told analgesia. Then you have told at this point of time, because what happens now, their question distribution is according to that question.
Okay,
Okay,
sir.
they'll be able to put answer or not. So you have to tell when it comes to that.
Okay.
Okay, admission anesthesia and antiemetics. Then CT angiography. These things you conveyed.
Yes.
CT angiography was done with short 70 millimeter and echo aneurysm.
Okay.
What next?
So now that the neurosurgery team is already involved, I would like to
Just
begin.
1 minute. 1 minute. I think I missed it. You said anti-epileptic drug, right?
Yes.
Routine anti-epileptic drug is contraindicated. In fact, phenytoin is known to cause more harm in these patients. Okay.
Okay.
Okay. Even if you want to give any drug, you can give Levipil, but in exam don't fall trap to the routine aid is not indicated in SAH.
Okay. Okay.
Okay. Yeah.
Okay, so now the neurosurgery team is already involved. I would like to, until they reach, I would like to manage the patient in the ICU. I would start him off now that airway, GCS is 15 on 15. So I assume that he's maintaining airway and breathing. And I would like to place an arterial line again to monitor his blood pressures and will target a BP of less than 160 millimeters of mercury, and start him off with maintain an IV fluid to maintain euvolemia, and also start him off with nimodipine as early as possible, 60 milligrams Q4 hourly, either oral or IV, and update family regarding the possible intervention that is required with the neurosurgery team.
What are the interventions you might be considering?
With him, I would like to do already CT angio is showing an anterior communicating artery aneurysm. So I would like to straight away go ahead either with the aneurysm coiling or clipping. So in this case, it is aneurysmal coiling, minimally invasive. So would like to go ahead with the aneurysmal coiling.
Okay, don't say what you do is we'll do a multidisciplinary meeting with the neurosurgery and interventional radiology and take a call about coiling or
Coiling or
on
clipping.
the aneurysm. You don't say about anything. You say that we'll do a meeting. Most important thing is secure aneurysm within 24 hours. You discuss with your neurosurgeon and interventional radiology, either coiling or clipping based on the aneurysm physiology, the morphology.
Okay.
Okay. You told this already, and the patient was shifted to ICU. What are other things you would like to monitor?
Patient, I would like to do apart from I would like to monitor his electrolytes, one. And second thing, I would like to look for immediate complications of SAH like rebleeding and vasospasm. So I would like to do a transcranial Doppler along with pupillary nerve sheath diameter to look for raised ICP signs.
Anything which you can do, very simple things which will determine patient is worsening or not.
The GCS monitoring.
Yes, you should say specifically neuro monitoring.
Neuro monitoring, yes.
Okay, neuro monitoring every hour. You're going to monitor the vitals, as you told, daily electrolytes already. Yes. Then imodepine and daily TCD in this
daily
case.
TCD. Yes.
Okay. What are the scoring system you are aware of? This generally they don't ask, they're not going to these kind of intricate details. Okay. What are the scoring systems you are aware of in SH?
Hunt and Hess and WFNS and modified Fisher based on radiology.
Okay. That's the exact thing you can read up.
Yes.
Okay. 4 days after successful endovascular calling of the aneurysm, patient becomes confused. TCS dropped to 13/15, and patient develops right side weakness. His BP is 160/95, heart rate is 90, and a repeat CT scan showed subtle ischemic changes in the left hemisphere. He remains afebrile. What is the most likely cause of this patient deterioration?
So it is 3 days after the coiling. So I would like to suspect vasospasm in him. Along with that, possibility of acute hydrocephalus and possibility of a seizure
Mm.
and a diffuse cerebral edema.
Okay. Okay. You said vasospasm, you said seizures. Did you say hyponatremia, dyslipidemia?
No, dysarectomy. No, sir.
Okay, hydrocephalus, yes.
Hydrocephalus, I have to diffuse.
Okay.
Yes.
So what is the most, these are the 4 or 5 things you should remember for SH worsening. What is the
Yes.
most likely cause in this patient now?
Possibly a vasospasm
Oh,
given SAH, and
oh,
also hydrocephalus also is a possibility. Yes.
okay. So what diagnostic test you like to order to confirm vasospasm, and how do you interpret the results?
I would like to do a bedside transcranial Doppler,
Mm,
and I would like to look at mean MCA uh, 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 velocity.
mm,
So anything more than 120 will suggest a vasospasm. And
mm,
also with that, I would like to look at a Lindegaard ratio.
mm.
That is the ratio of ipsilateral MCA velocity, mean MCA velocity with an extracranial ICA velocity. Anything above 3, I would like to consider as a vasospasm. Anything more than 6 is severe vasospasm.
Is there any other way we can confirm the vasospasm?
We can do a DSA as well.
Okay, fine. Okay, this patient TCT was done. We showed MC velocity of 180 and Lindegaard ratio of 4. How do you manage this confirmed vasospasm?
I would like to maintain a euvolemia. And second, I would like to recheck if the nimodipine is continued or not. I would like to continue that. And third, I would like to maintain hypertension. I would like to mm, mm. And if all this doesn't work, even intervention with stenting would help. DSA and stent.
Any other intervention?
Intra-arterial, it's not regularly used, but however it is mentioned, papaverine can be used.
Yeah, intra-arterial nimodipine, papaverine.
Yes.
I think you mentioned about angioplasty also.
Yes.
Now that the thing is coming is milrinone infusion.
Milrinone.
Okay, so more or less you told all of them. Okay, now 5 days after admission, patient developed altered sensorium. GCS again drops to 12/15, and patient experiences GDCS lasting 2 minutes. Lab showed sodium of 120, urine sodium of 150, serum osmolarity 270, urine osmolarity of 500, CVP is 4, blood pressure is 130/80. The seizure was aborted with lower the pump.
Okay.
Okay. So, what is the most likely cause for this hyponatremia in this patient?
Possibly cerebral salt wasting syndrome.
Mm.
Because there is hypovolemia with hypotonic hyponatremia.
Mm.
So possible CSW is cause for hyponatremia.
How will you differentiate from SIADH?
Mostly the SIADH is euvolemia, and we could use even the uric acid as a marker to differentiate. In CSW, it is high, or it can be normal. In SIADH, it is low.
Okay. Okay. Mainly SH and CSW always. Okay. You
Yes.
have covered most of it. How will you manage this hyponatremia and seizures?
So here I would like to start with 3% saline and target a rise in sodium of 6 to 8 milliequivalents in 24 hours. And at the same time, I would like to start a anti-epileptic drug, Levipil, 60 milligram per kg body weight.
Okay. If there is no seizures, how would I manage this patient?
If there is no seizures, if it depends on how symptomatic the patient is. So if patient is asymptomatic, then I would just correct his volume and monitors sodium serially.
Okay.
And again, aim for
Will you
these
correct the volume?
based on the free water deficit. I would like to calculate
What is why free water deficit? It is hyponatremia.
hyponatremia.
How will you give the volume? Saline resuscitation.
Okay, what? Okay.
Okay. Then any other medication you can give in this condition?
We can give tolvaptans.
No. CSW. Why you will give tolvaptan in CSW?
Oh,
Fludrocortisone.
fluorocortisone, yes.
Okay. So 10 days after admission, successful calling of of the aneurysm. He has been stable after management. He has been stable, but now presents with progressive drowsiness, headache, and vomiting. His pupils are equivalent reactive, but he has the sluggish responses. Vitals show BP of 170 by 100, heart rate of 60, respiratory rate of 14, temperature of 37.1. The repeat scan revealed enlarged ventricle compared to the prior scans. What is the most likely diagnosis based on presentation, and how does it happen?
It's a possibly acute hydrocephalus.
Mm.
Maybe due to the thrombus, the SH blocking the ventricular drainage.
Okay. Okay. Fine. What are the interventions you would like to do in this patient?
So I would like to intubate the patient and intubate and control ventilation. Along with that, head and elevation, and give him a 3% saline. Meanwhile, inform the neurosurgery team and would like to inform them for an emergency external ventricular drainage. And yes, sir, all this.
See, we discussed already. In any brain patient where a raised ICP is there, what are things you are going to say?
Intubate, sedate, paralyze.
Yes.
And I told all, yes. And start head and elevation and give a anti-edema measure with either 3% saline or an mannitol.
Yes.
And meanwhile, intimate the neurosurgery team for an EVD placement.
Okay. Normothermia,
Normothermia, normocapnia,
patient is also permission
normoglycemia.
is there, you can hyperventilate the patient.
Yes.
Okay. Those are things you will automatically say in every patient so that you don't miss anything.
Yes.
Okay.
Yes.
So neurosurgeon places an EVD and initial ICP reading is 28 millimeter of mercury with a CPP of 25. How do you manage this elevated ICP?
So this I would take anything more than 20. I would take as very high ICP. So uh, I would like to do the now that EVD is already placed. I would like to drain the EVD. Second, drain CSF through the EVD. Second, I would like to continue the osmotic diuresis with mannitol or 3% saline, and also maintain the normocapnia, normoglycemia, normothermia, and head and elevation to, and no extreme neck flexions.
Yeah. You told everything except for one more point. In the question
Hyperventilation.
only it is there.
Sir?
In the question only it is there.
Is an EVD and initial ICP. CPPS, blood pressures.
Target a CPP of more than 60 to 70.
Yes.
Okay, those things you should say, and less than ICP less than 20.
Yes.
Okay, this you should verbalize all these things.
Okay.
Okay. A patient stabilizes with at 15 millimeter of mercury with ICP, but 2 days later it develops fever and cloudy CSF.
7344.
What is
Okay.
your next step and how do you manage this complication?
So
Our railway
it could be a
1 minute.
meningitis.
1 minute. Yeah, you can go ahead now.
Patient has developed a fever over an EVD, so I would like to suspect more of a meningitis through So I would like to send a CSF
What will you suspect?
EVD
Do we call it meningitis?
ventriculitis.
Yes.
Yes. So I would like to send the CSF from the EVD for analysis and start him
What
on
all analysis you'd like to do?
CSF cell count, cell type, protein, and culture.
Okay, Grafton.
Gram stain, yes.
Okay, how will you manage?
And I would like to start him on broad spectrum antibiotics.
Hmm.
And would request, if at all this EVD, the
What
CSF
you do is, I'll start an empirical antibiotics based on local antibiotics.
local antibiotic. Yes.
Because different institute have different practices. You just mentioned that.
Okay, sir. And would request a neurosurgeon to replace EVD or remove EVD in case the CSF comes positive for the organism.
Okay, fine. Okay, these are more or less the case. Just to finish it off, what are the extra neurological complications in SH?
One, the sympathetic surge
Hmm.
causing Takotsubo cardiomyopathy, and
Yeah, tell me. We discussed two of it already.
and
Cardiomyopathy, arrhythmias can happen.
yes.
From respiratory, any complication you are aware of?
ARDS, non-cardiogenic pulmonary edema.
Neurogenic pulmonary.
Neurogenic pulmonary.
Okay, from the endocrine perspective?
DI or
we discussed two of them.
taste.
DI, then electrolyte.
That's it.
Uh,
This electrolytemia.
what are the dyselectrolytemia we discussed?
Hyponatremia, more of CSW or SIADH related.
Yes. Okay. Okay, that's it. I think we have covered SH related most of the complications which might come. As I told you, there are certain protocols you should fix to. Example, ICP, what are the things? ARDS, what are the things? Sepsis, what are the things? These key questions keep coming in one or the other pattern. Generally, ARDS will come in one or two scenarios in the exam. Sepsis will come in one scenario. For that, you should be mentally ready. Okay, if it comes, you should tell direct example. If it comes to sepsis, I'll put a 2 large bore access, a fluid dose, then lactate, then blood cultures, then antibiotic, then ABG monitoring. These are things which are going to say in the exam without thinking twice. Okay, just make sure that you revise it, and literally there are few things you have to buy heart. Raised ICP things you need to buy heart. IRDS things you need to buy heart. Okay.
Yes.
Always differential, give 4 to 5 diagnoses. Don't stick to one. Always see, in any question, there'll be 4 to 5 points they'll be expecting. There might be more in your mind, but try to say whatever is possible and try to say it in short span of time. Don't beat around the bush in the exam because time is only 25 to 30 minutes. You don't get more time than that.
Yes.
Okay. Today, I think we are able to cover 2 sessions. Hopefully, it will find useful to you and others. Thank you, everyone, for joining.
Thank you, sir.
If anybody wants to ask any questions, they can ask from there.